Hello, everyone, and welcome to Expecting Health's latest webinar, Casual Conversations, Challenging Topics, Being Black in Healthcare, Patient and Provider Views. I am Dr. Eboni Drummond, and I am the Senior Manager of Health Communications for Expecting Health, and I will be moderating today's webinar. First, I have to start by saying that the speakers that you're about to hear from are absolutely amazing. When I first heard both of them speak, I found their stories and messages to be very impactful. And so I'm very honored to have both of them here with us today. So before we dive into the webinar topic, let's go over a few logistics. So during this webinar, our speakers will share their experiences navigating the healthcare system. So that's what you can expect throughout this webinar. Also, we are recording this webinar and it will be available on our YouTube channel in the upcoming weeks. And lastly, if you have any technical issues, please let us know in the chat box. And also, if you have any questions throughout the webinar that you would like answered, please enter those in the chat box as well, so that way we can address them during our Q&A session. Okay, so why this topic? Implicit bias and systemic racism. Because of implicit bias and systemic racism, Black people are more likely to experience disparities when navigating the healthcare system. And this results in Black patients being more likely to distrust research, such as clinical trials and studies, as well as the healthcare system as a whole. In addition to this, they also receive lower quality care. And these disparities can then also lead to Black patients being more likely to be dismissed and have their symptoms and concerns minimized, which can lead to being misdiagnosed and undertreated and ultimately higher mortality rates. So just a few specific examples, because we've seen a lot on social media and in news and journal articles. And so I'm pretty sure that some of these are not new. But just to highlight a few examples, Black women are 3 times more likely to die during or after childbirth, than white women, no matter their income, occupation, or education level. Black people are being underrepresented in research studies and clinical trials. And that means that researchers and providers lack the data that they need to know how rare diseases affect Black people and how to tailor care and treatments to meet their specific needs. And lastly, research has shown that Black people are less likely to receive pain medication. And if they do, they generally receive less than what would be given to a white person. So on this slide, you can see a few headlines that I've captured here that kind of showcase and highlight exactly what we will be talking about, and then also those examples. So the goal for this webinar is to connect what we've read and seen regarding this topic to real stories and experiences that our speakers are going to share with us. And then we also want to provide everyone with action items that they can use, that we can all use to hold ourselves accountable as we continue to fight for health equity. Okay, so now that I've given a little background about this topic, we can go ahead and dive right on in. I want to introduce our first speaker, Dr. Michele Wright. Dr. Wright has advanced degrees in engineering and public policy and is the co-founder, board chair, and senior executive director of the National Organization of African Americans with Cystic Fibrosis and the director of business development and outreach for the Society of Motion Picture and Television Engineers. She has created award-winning edutainment platforms, co-founded and co-chairs the annual Blacks, Indigenous, and Other Minority Ethnicities with Rare and Genetic Diseases, otherwise known as Biomerged, conference, and has developed and launched the Advocating for Health Equity and Addressing Disparities initiative. So please welcome the 2022 USA Today Woman of the Year for Arkansas and the 2023 AARP Purpose Prize Fellow, Dr. Michele Wright.
Thank you so much, Dr. Eboni. And it is such an honor to be here at the table, not only with you, but Dr. Fair. And what a most important topic. It's interesting because recently, and this was just this month, I read an article and I have it in front of me. It was titled, "Should the medical world reconsider the use of race in medical algorithms?" And what was interesting about this article is how it addressed the potentially dangerous consequences of using race in medical algorithms. The article was written by Dr. Joseph Wright, no relation to me, but he expounded and shared some unique things. One of the things that he shares is that the medical practice is historic in nature, steeped in historical biases, racism, and assumptions used by physicians for several hundred years to assist in evaluating diagnosis and treatment of patients. And he goes on and talks about how the practices often use Black and non-Black classifications as one of the predictors. But he elaborates, and this is his statement, it's not the race assignment, but the actual bias that people experience that contributes to the differential harming and damaging outcome. He continues, there is a strong social component to race, but there is also a genetic component, and genetic variants have biological consequences. So in addition to social factors, our research studies need to account for as much genetic variation as possible. And one way he recommends this can be done is for studies to include participants from diverse genetic ancestries. Now, I can tell you why this really got my attention, because when I think about cystic fibrosis, it is underdiagnosed in the population of BIPOC people, Blacks, Indigenous, and people of color. And it's also thought to be a white person's disease. And I know this firsthand because of my husband's own journey to getting his diagnosis of cystic fibrosis. And what was unique with my husband is that he has 2 rare CF mutations. So even if they would have had newborn screening during the time my husband was born, he's about to turn 61 years old next month, they would have missed it because of the rare mutations. And the rare mutations they typically test for are going to historically catch 90%, the death rate of white people with CF, and a lot of times miss the BIPOC populations. And that's one of the reasons we not only started the National Organization of African Americans with Cystic Fibrosis because of my husband's diagnosis at the age of 54, but we actually developed the right cystic fibrosis screening tool to ensure, especially people who are BIPOC, don't fall between the cracks because they have a tendency to have rare mutations. It's interesting, we've helped 2 young ladies recently. One couldn't even get a sweat test because she's assumed to be African American. And another one that could get a sweat test had rare mutations. So she couldn't get the diagnosis of cystic fibrosis because the doctor did not understand how CF variants differ in people of color. So we have come a long ways, but we still have so far to go. And again, that's why NOAACF is so important because we come to the table to educate, engage, CF awareness in diverse communities. One question I get asked quite often, how do you know it was based on race? Fortunately, in my background, I was a pharmaceutical biotechnology representative for about 15 years. And one of the drug classes I promoted was antibiotics. You may can tell now I have a slight respiratory deal going on, but I knew the symptoms of any type of upper respiratory infections, bronchitis, sinusitis, pneumonia because of the pharmaceuticals and biotechnology drugs that I promoted. So when my husband said my chest hurts, I said, let's go to this walk-in clinic. It sounds like double pneumonia to me. That was early 2000. And the doctor at that time said, if you were not Black, I would say you had cystic fibrosis. That was the first time we heard of cystic fibrosis. And one correction, actually he was my fiance, because this happened in early 2000. We got married November 4th that same year. That was the first time we heard cystic fibrosis and the last time until 17 years later. And at the time he got the diagnosis 17 years later, I often wonder, what if it were not that doctor who was there that day? What if it could have been one of the many other doctors he saw throughout this 17-year journey? I can tell you, my husband was hospitalized early on as a child. They labeled it everything but cystic fibrosis. They said he had a nervous stomach. They said he had asthma. You know, everything that checked the box but cystic fibrosis. He even in 2001 had an 8-hour pancreaticojejunostomy because his pancreas was so severe and damaged from chronic pancreatitis that they had to do that procedure. This is what's really disappointing. Stereotypes are real, but we have to make sure that doesn't take place in the medical profession, especially being BIPOC, which I'm so excited about Dr. Fair and what she has to share next, because with unconscious bias, you're going to miss things like that. You're going to miss things and make assumptions like what was done with my husband. When I think about all the surgeries, all the pain, all the suffering, we were making an average of 1 trip a week to the emergency room just for him to get Demerol and Finnegan for pain because of the attacks in his GI, the pancreas, and all the other things he was dealing with. This is what's interesting. My husband is an athlete. So even with all the health problems he has, at that time, he was running marathons and in pretty good shape. He used to always complain to the doctor, why do I have all this salt on my body? You know, head to toe, covered in salt. They say it's probably just dehydration, but that is the classic #1 sign of cystic fibrosis. That should have made any doctor, the light bulb go out and say, wait a minute, you don't fit the bill for cystic fibrosis, but let's rule it out. And that's why sometimes I encourage people, if nobody else advocates for you, make sure you are advocating for yourself. And that's why it was so important to us to start this organization. You know, so many people said, weren't you angry? Weren't you mad? Weren't you frustrated? We decided we could either take that route or take our journey and let it make a difference in the lives of others. And we are making a difference. Those two ladies I told you about, I won't call their names, but they didn't get help where they were located, but we were able to triage them to Dr. Jennifer Taylor-Kauser, who ended up helping these young ladies and still in the process of helping them. So it takes a village. And I think about my village, even with my husband recently being hospitalized for 2 weeks, I had a village I could reach out to, not only Dr. Jennifer Taylor-Kauser, but Dr. Susanna McCauley, Dr. Megan McGarry. And in the process, you learn all these things you may not learn. But I do appreciate Terry C. Elf Clinic too, on the University of Arkansas Medical Sciences, because they are doing a phenomenal job. Dr. Larry Johnson, Dr. Jagana, and treating him. Ironically and interesting enough, his doctor is African-American, Dr. Larry Johnson. Sometimes I do think that can make a difference in making sure you being heard and listened to. And again, I stress and continue to stress, advocate for yourself. You may not be fortunate enough to see a Dr. Fair, but your own voice and advocacy means so much. And if you get to a point you're tired and you no longer feel the strength to advocate for yourself, reach out to an organization like NOAACF, and we'll advocate and fight on your behalf. And that's what I appreciate about your organization, Dr. Eboni, what you all are doing in the rare disease, expectant health in the rare disease space. So we are continuing to do what we can. My dream is to one day have an international health equity center of excellence. So people from around the world that's not getting the health equity care they deserve, which all of us and any of us should get, regardless of race, ethnicity, socioeconomic status, disability. We all should be treated according to signs and symptoms. And sometimes we have to go back to the medical schools, to the residents, and correct some of this misinformation and stereotypes. It doesn't happen, correct some of the curriculums. It doesn't happen overnight, but voices like ours, voices like yours, Dr. Eboni, voices like Dr. Fair, working together in synergy truly makes a difference. And I just want to thank you for the opportunity to come to the table and share our story. I do want to say this too. Inequality comes a lot of different ways. It comes not only in diagnosis and sometimes treatment and just different aspects of the healthcare environment, but also support. It's so important to support organizations that voice is making a difference in the BIPOC community. So often, and you know this firsthand, Dr. Eboni, so often people want to use your services but not support your cause. And again, those ladies I mentioned earlier, I'm so grateful to them. I'm grateful to the CF community for their support. I'm grateful to the Cystic Fibrosis Foundation for their support, and other organizations, sister organization, Cystic Fibrosis Research Institute, the Laura Barnell Foundation. And I do want to give a special shout out to our patient advocate, Rachel Adler. I won't mention the other young lady's name because she's still in the process of going through what she's going through, but it does take a village. And again, I'm grateful to have you both a part of my village. Thank you.
Hi, this is Vicki Hunting. That was awesome insight, Dr. Wright, but I'd like to call attention to some of the comments in the chat that way it came up while you were talking. Someone mentioned, Angel mentioned that this is so needed, that in nursing school, she learned that CF was a white people's disease. Others have commented that as a biology and genetics educator, she agrees. The textbooks and course materials do not have people of color when it comes to CF. And unfortunately, textbooks and course materials are not culturally competent at all and need significant revisions, like you mentioned earlier. And then somebody else mentioned that she works in newborn screening now and recognized that they're finding and seeing more cases in people of color in the newborn screening area. There was a question that was asked early on, and it'd be interesting to see what your thoughts are about this, and Dr. Fair as well. The question is, are Black people underrepresented in clinical trials because they aren't being given the opportunity to participate? Or is it because of the underlying distrust of the healthcare system that many Black people may experience?
What's interesting, I was born in Tuskegee, Alabama, at the same hospital they did the Tuskegee syphilis experiment. And we know that there is a mistrust for African Americans with clinical trials. And I am fully convinced, as many others, a lot of that stemmed from the Tuskegee experiment. But it makes a difference when you come to organizations like NOAACF, you know, like Expectant Health, like Dr. Fair, because we have a better outreach to reach the people that look like us, and it makes a difference. I feel sometimes having Black doctors to help recruit makes a difference. I think about my husband's relationship with his doctor, and he just says, Terry, I need you to do this trial. And Terry's like, okay. And it's not just Black physicians. I also mentioned like a Dr. Susanna McCauley, Dr. Megan McGarry. They're not BIPOC, but they do so much in the BIPOC community. So I would trust them as well. And you just know when a physician heart is sincere about listening and making a difference in the BIPOC community. But I think it's to answer that question, I believe it's a combination of both. You do have mistrust, but you can work towards overcoming those challenges and filling those gaps.
Thank you. Absolutely. The network is so important. Anything else before I turn it back over to Dr. Eboni?
I don't see anything else in the chat right now, but keep it coming, everyone. Great comments and questions for sure. So thank you, Dr. Wright, for sharing you and your husband's story. It hit me this time just like it hit me the last time. It's just such a powerful story to share. And this, again, helps us connect everything that we've read and what we see on social media with real stories and real faces. So thank you so much for sharing that with us.
It's my pleasure. Thank you.
Okay, so now I want to shift gears just a little bit and have us all look at things from the Black healthcare provider perspective. And so our next speaker is Dr. Malika Fair. Dr. Fair is the Senior Director of, let me get her slide. Dr. Fair is the Senior Director of Equity and Social Accountability at the Association of American Medical Colleges, AAMC. Dr. Fair develops programs and initiatives with multidisciplinary partners and local communities to advance equity, racial justice, and population health and accountability through a continuous equity improvement lens. Dr. Fair leads the AAMC's Equipping Academic Medicine to be More Inclusive and Equitable action plan created to address and eliminate racism within academic medicine. So that kind of ties back into what Dr. Wright was saying a little bit earlier. She also oversees the Office of Community Engagement and is an associate clinical professor and practicing physician in the Department of Emergency Medicine of the George Washington University. She received her medical and Master of Public Health degrees from the University of Michigan and her Bachelor of Science from Stanford University. So everyone, please help me welcome Dr. Malika Fair.
Thank you, Dr. Eboni, and it's just a pleasure to be on this panel with Dr. Wright. When Dr. Eboni invited me to join, I told her that I don't know if I'm more excited about the opportunity to meet you all and to be part of Expecting Health or a chance to listen to Dr. Wright. So, but I'm glad I was able to do both today. I would like to share just a few slides and we'll see if this works okay. And give me just 1 second here. Okay, do you all see my slides?
Yes.
Okay, and you see it in slide version, not the notes?
Yes, that's correct.
Great. All right. So I just want to speak briefly about Dr. Wright's story from a physician standpoint and to acknowledge that the experience of her and her husband is unfortunately not unique. And there's a reason for that. The reason is that there are structures and policies that are embedded within medicine that are racist. And it doesn't mean that every person is racist. It doesn't mean that there's intentional actions being done every day, but it does mean that when you go back and when you look in terms of specific structures and policies, that there are things there that shouldn't be there. And we're collectively working to get rid of those. But what you see on the screen here, I'm taking you back really far. This is all the way back to 1767 to be exact, where Carl Linnaeus, and excuse me for the background noise if you can hear that, Carl Linnaeus was a physician who did a study and he came up with a taxonomy of what are the races in America. Now, all of us have seen this taxonomy because we've learned about Homo sapien, we've learned about the different classes of plants and animals. But I was unaware that back in the day in the 1700s, that all of us were classified in 4 races. And they were European white, American reddish, Asian tawny, and African black. Now, if you hear those 4 categories, you might be thinking, well, based on skin color and hair, maybe I can see putting people into those 4 basic categories. It's not the same races that we use today, but maybe I can understand the rationale. But what's insidious about this taxonomy is that it wasn't just about the way someone physically looked, because you can argue that maybe there's a biological component to someone's skin color, but with each one, there was a description of their characteristics. So for example, for someone who was white, they said they were cheerful, muscular, wise, an inventor, and they were governed by religion. For someone who's Black, which was at the lowest of this taxonomy, they described them as sluggish, sly, neglectful, lazy, and governed by choice. Now, this is outside of any physical characteristics, but the problem with this, besides that the language, which I'm hope is probably disturbing to you all, is that this was a medical document. This became science, and studies were done after this. And, this part of it still remains in practice to this day, where we as a medical profession adopted this belief that race is based on biology. And instead, it's a social construct. It was made up. And you can see what was thrown into these categories. Now, is race real? Absolutely, in a social sense. I'm impacted by my culture, my religion, how I was raised, and I proudly identify as Black in America. But under a microscope, there is very little that you can genetically say, I don't have a Black gene. And race is not based on biology, but this is something that's not completely understood right now in medicine. Now, if you fast forward about 100 years, and this picture is clearly more recent than that, but Samuel Cartwright was another physician who believed in this taxonomy that Carl Linnaeus had, and he did a study on lung function. He was looking at those who were enslaved and measuring how deeply they were breathing. He created the spirometer and decided that because those who were enslaved, after working all day in the fields in the hot sun, that they didn't seem to have as significant of lung function compared to himself, who was sitting there observing them all day. And because of this, he concluded that Black people have lower lung function than white people. And you would think that that sounds a bit, short-sighted, but some of those calculations are still in use to this day. And you heard Dr. Wright talk about the clinical algorithms, how race is being used. But even to this day, we're having to remove some of our pulmonary function that uses a race correction factor because of studies that were incorrect even back in the 1800s. Now, let's hope that now in the 2000s, all that's gone away. Unfortunately, it's not. So this study that you see on the screen cited was back in 2016, and medical students were interviewed, and a large percentage of them, over half, believed that Black people had thicker skin, that our blood clotted more, that we experience pain less. So this is not that long ago, which means we have a lot of work to do to instill in the next generation of not just physicians, but all health professions, that race is a social construct, and that these ideas that we have that we can just put everyone in a box and say, well, all Black people have X, all Black people don't experience pain, or no Black person could have cystic fibrosis, is false. And the more that we continue to have these beliefs, the more people who are going to suffer, just like Dr. Wright did. I'll show this picture because, as Dr. Eboni mentioned, I am an emergency physician. Although I'm not practicing right now and spending a lot more time with my 3-year-old, who you may hear through my microphone. So sorry about that. But this screen here is what we see when we log into the emergency department. We're waiting to see patients. We glance and see who's in the waiting room, who's next to be seen. And even just by opening up the screen, bias can already enter. You can look at a last name of someone who may be Spanish speaking and think, oh, maybe I'll see someone else first because I might need an interpreter, without even asking whether they speak English or not. You can look at a chief complaint, and if it says sickle cell disease, then providers may say, oh, that's going to be someone who is probably not sick. They can wait in the waiting room, and they're probably just, asking for more medications for pain. They might even be a drug seeker. Even with those two, I hope, egregious statements that I've just said, I've seen this happen countless times. And that means the bias can start even just by opening up our screen. So we have a lot of work to do to not associate race immediately with a patient's presentation, their signs, their symptoms, before even asking any questions of that patient. And the reason why this happens is because of how we're trained. We're trained to recognize patterns. We learn about them in textbooks, we hear about them, we read cases in medical school, and then we see hundreds upon hundreds of patients. We see the same patterns over and over again. And oftentimes, if we associate race with a pattern, it's hard to get out of that cycle. What was really striking about what Dr. Wright said is that a clinician 17 years before her husband was diagnosed said, this is a pattern that I've seen in cystic fibrosis, but it couldn't be you because you're Black. And it then took 17 years for someone to step outside the box and say, yes, this is a pattern that I recognize. Maybe not with the skin color that I've seen, but I'm sure that this is cystic fibrosis. And that's the kind of thinking that we need in medicine. So I'm going to shift. This has a lot on the screen here, but I'll give you a little bit of homework. Dr. Eboni will drop a link in the chat. This is what we are hoping changes in medicine from the provider side. What we're sharing with you are diversity, equity, inclusion competencies that we expect for graduating medical students, those who are in residency about to start their practice, and those who've been practicing for 3 to 5 years. Now, this is not mandatory. This is something that we hope that our colleagues adopt, but we think that these list of competencies, if adopted, can change the way we are practicing medicine to be more equitable, inclusive, and to represent the diversity of our population. So I'll go through these fairly quickly, and I heard it mentioned already today. The first one is within diversity number 4, is that we have a responsibility to advocate for policies and practices that promote, build, and sustain the diversity of our healthcare team. When you have a diverse healthcare workforce, you have better access to care, higher patient quality of care. In some cases, there's been studies that if you have more Black physicians, primary care physicians in the area, the life expectancy goes up of that population. And even within the learning environment, the learning that you have in medical school or in any educational environment improves when you have more diversity in that class. I think about the clinician that diagnosed Dr. Wright's husband 17 years later, and I wonder about their training. I don't think, when I've heard this story before, I don't think that clinician was BIPOC, or maybe they were, but they may have been in an environment that was very diverse, and they understood the variations of race and genetic ancestry, and they were able to think outside the box. We know that clinicians, when they are trained in a diverse environment, they think differently and they practice differently, and this is what we want to advocate for. The second one is equity number 8, which is how can we identify and correct the clinical tools and practices that substantiate race-based medicine. Essentially, those algorithms that you heard Dr. Wright talk about, the ones that are currently in use today, thankfully, many of them are changing. We have students and we have faculty members who've said enough is enough. Let's remove race out of the GFR or our kidney function test, because it's based on a faulty assumption that Black people have more muscle mass and our kidneys work differently. Or those pulmonary function tests that are based on that study from Samuel Cartwright in the 1800s. Or even for someone like me who's had a C-section, the vaginal birth after C-section calculator, where thankfully they've removed race altogether in that algorithm that can impact, birth outcomes for Black women and our children. So we have a lot of work to do, but I'm proud of the progress that has been made to call this out, to acknowledge that race is a social construct, and to reevaluate all of these calculators and tools that we use every day in medicine. The third is equity number 2, which is, we've heard this mentioned today already. How can we as clinicians identify, mitigate our explicit and implicit biases? We all have them. I was raised in the Midwest in a Pentecostal Christian family in a 2-parent home. And my biases, when I walk into a patient room, I'm carrying all that with me. But there are strategies that I have to do every time to mitigate my bias, so that even though I come from a rich cultural background, I'm not automatically assuming that someone fits into a perfect box that I've created in my head. And the last competency is, and let me just move this here on the screen, equity number 5, which is how can we explore stratified quality improvement data to identify healthcare care disparities? What this means is you've heard it said that you want to go to a good hospital and you want a hospital that has high quality of care, which I agree with. But oftentimes those quality metrics are looking at everyone. It's a general quality score. What we really should be asking for is, does every group get quality of care? If you look at just marginalized patients, just Black patients, just Hispanic patients, just those who live in a certain zip code that has lower social economic status, or LGBT patients, are they getting the same care, or are there differences? And this is the responsibility of academic medicine and medicine in general, to look at our data, to cut the data by these categories and make sure that everyone's improving and everyone's getting great quality of care and not just the general population. So I'll end here with 3 questions that I think all of you should think about as patients and as advocates for your family members, because there is a role that we should play as providers, but there's a role that we can play as patients as well. We should ask our physicians, our nurse practitioners, our physician assistants, what decisions have you made today based on my race? Now that question may seem a bit hard to ask, but you can ask it and say, did you use any calculators or algorithms today that included race? Is there anything about my race that influenced your decision today that you think is more or less likely because of my race? I think the more time we're asking these questions, the more this becomes normalized and we can have a better conversation about this. The second question is asking them, how did they eliminate their bias in the practice today? What strategies did you use to mitigate your bias? Now, people may be taken aback by that. They may say, I'm not racist. I treat all my patients the same. But the reality is we all have bias, whether you come from a historically marginalized or excluded background or not. And we all can take those strategies, those evidence-based strategies, to reduce bias right there at the bedside. And then finally, if you have a diagnosis or they're considering a diagnosis, we should ask, what are the health inequities for my race? This is important because we need to know what we're dealing with. Is it because Black patients tend to do worse in a particular diagnosis because we have less access to care? We're getting diagnosed later? Or is it because maybe there's a genetic ancestry component because we may come from a certain part of West Africa or a certain part of the Caribbean? But I think that these are questions that have to be asked so that we're not just lumped together. We don't just assume that because you're Black, you are automatically sicker. It's just not true. There's usually a reason, and we have to hold the healthcare system as well as our providers accountable. So I'll stop sharing here, and I look forward to any questions. But again, this is a privilege just to be part of this conversation today and to share the floor with Dr. Wright.
Thank you so much, Dr. Fair, for sharing. I hope you all can see just how powerful both of them are and why I wanted them on this webinar, to be able to share their stories and just their experiences navigating the healthcare field from 2 totally different sides, but how interconnected the stories and experiences are. So let's see. Now we are, I think there was another question in the chat. Let me go back. Okay, so we often talk about, like we've talked today, about how important diversity is in the medical field and research field. Do either of you think that this puts the burden on other BIPOC providers instead of the entire field?
So, I can start. There is definitely an increased burden on minoritized physicians and other health providers because sometimes we feel the burden to take care of our own, to right the wrongs, to ensure that these inequities are reduced or eliminated. And there's something well studied called the minority tax, because we end up in addition to doing research and practicing, we mentor, those who are in our same group. We are working with our communities. We are working on committees of DE&I in our institutions. We're doing the most. And there is an increased burden there. But what I want to emphasize is we won't make significant change if we don't have everyone involved. It is not just the responsibility of marginalized clinicians in general. We need allies. We need everyone to be on board. And as I mentioned before, the research strongly supports that we just practice better medicine when we have diverse teams. We learn better when we have diverse teams. And if we can capitalize on the broad benefits of diversity, and if there's others who can buy in, we'll have more allies who are doing the mentoring, who are also serving on those committees, who are also doing the research so that we can share the load and really move the needle to eliminate health inequities.
I agree totally with Dr. Fair. I mentioned Dr. Jennifer Taylor-Kauser earlier. She's in Colorado at National Jewish, and these two young ladies, I had to get from their location hours and hours away to go see her. And so she selfishly took on the burden of everything she's already doing, her medical responsibilities, traveling and doing all these other things, even in DEI, to take on these two additional ones. And that's why the Health Equity Center that I foresee having one day will make a difference, because at that point, you bringing different advocates across the nation to the table, and the referral network could actually refer to people like a Dr. Fair, and not just like a Dr. Jennifer Taylor-Kauser, but a Dr. Susanna McCauley, a Dr. McGarry, and others that are advocates for health equity. But one thing I want to stress, you need DE&I, because to me, diversity brings you to the table. Inclusion is going to allow you to partake in what's being served, and equity is going to ensure you have your due serving. So if anyone is trying to do diversity without equity and inclusion, it's just a check in the box and not a heartfelt initiative. Thank you.
No, I definitely agree with that. Thank you both for answering that question. Another question is, what advice would you give to our attendees, if you haven't mentioned it already, who want to take a more active role in raising awareness for health equity?
I can tell you, get involved. There's not many organizations like NOAACF, the National Organization of African Americans with Cystic Fibrosis, but get involved and support the organizations that's targeted, that mission, goals, objectives are all focused on these underserved, underrepresented, disadvantaged, marginalized communities. So often, like I mentioned earlier, we come to the table for our wisdom and for our ideals, and sometimes just to get the check in the box, but we need support too. So whether it's Expecting Health, whether it's supporting physician initiatives like Dr. Fair, just get involved in some capacity.
And I would agree with everything that Dr. Wright just said. And also on an individual level, regardless of where you work, but if you are a part of the healthcare field broadly, ask yourself those questions. Who is not here at the table? I love the table analogy that Dr. Wright just mentioned, because we have busy lives, we're trying to get through the day and get to our families and make an impact in this world. But if you realize that it's a homogenous group, that everyone only looks like you or only represents a majority group, then maybe that needs to be changed. Who can you mentor? Who can you make sure gets a seat at the table and is not only at the table, but is allowed to participate and has a voice? Because I think it takes every person asking those questions and making sure that they are making space. It doesn't mean that anyone has to give up their seat. It does mean that you got to add more chairs to the table so that we can all participate. And then for those of you who are clinicians or you're working in the healthcare field, I would also encourage you to question your data. Because oftentimes there's a dashboard somewhere, there's a report somewhere that talks about the quality of care that's being delivered. And we need more people to ask the E question. Is this equitable? You know, is every group being reflected in this report? And have we even looked at it? Because oftentimes, and if you're familiar with the 6 pillars of quality of care of safe and patient-centered and effective, we just forgot that equity has always been there. It's been part of the 6, but it just hasn't been a focus within medicine. And so we need individuals to ask those questions.
Okay, and we have a couple more questions coming in now. Before I read those off, though, I'm going to go ahead and go to this slide. So while I am asking this question or these questions and our wonderful speakers are providing great answers, if everyone could please take a moment and just complete this quick survey. It just helps us get better at the content that we're putting out for you. So the next question is, well, what can non-clinicians do? How can they support removing race from like kidney tests, kidney function tests, and lung function tests, like what you were speaking to, Dr. Fair?
I would like Dr. Fair to take this one.
Sure. There's a lot of things that you can do. I am very pleased that the national organizations, and I cannot remember the name now, but the national organizations representing nephrologists have come out with a statement saying that it's time to shift and we need to remove race. And instead, they've proposed using a different method to look at kidney function. So this is a huge win, coming out of a national organization. And we've seen several academic medical centers and medical centers in general across the nation make that switch, but it's not 100%. So I would look at, if you are a non-clinician outside of the hospital, then I would write letters to your local hospital, to your local CEO. I'd go into your MyChart or whatever kind of patient portal you have, look at your kidney function and see if there's race mentioned, because usually it's right there. It says GFR and it has a regular number, then it has black underneath it and it has a separate number. If it's there, it shouldn't be there. And so I would tell your clinician, your physician that, hey, I noticed that there's race in my lab reports. What is this about? And is this something that you can work on? And then write a letter to the CEO of the hospital, write a letter to your local even patient advocate, because this is something that will also take patient voices and patient advocates to say enough is enough. We're not going to accept clinical care that's based on racist ideology that's structural, that's been there for a long time, and we're finally realizing this. And I have to admit, I practiced for over 10 years. I was in medical school. I saw this. I never even questioned it because I just said, whatever, this is just part of medicine. And it wasn't until someone else, an article that came out recently called out a lot of these articles, a lot of these algorithms. That was in 2020 in New England Journal of Medicine. I think the title of the article was Hidden in Plain Sight. And it just hit me like a ton of bricks. And I said, man, I'm an advocate for equity. And this has been sitting right in front of me for years. So I think that we all have a role to play, and I'm just excited by the momentum so far. And the GFR means the glomerular filtration rate, which is just a fancy way of saying how the kidneys are able to clean out the blood. But if you look in your lab reports, you will see that GFR, glomerular filtration rate, and it will have the two races on there, or they'll have all others and then black.
Thank you for answering that, Dr. Fair. I'm going to go to Expecting Health's contact information while I ask the last question, which was, does Medicaid coverage compound bias?
I would say this is a lot of stereotypes with Medicaid. I just say it without saying it. And sometimes I truly believe having Medicaid or having no insurance can make a difference of how you are treated. And Dr. Fair can speak more to that directly. As far as your quality of care, and it shouldn't matter. It shouldn't matter if you overinsure, underinsure, or non-insured. You should be treated with the same level of equity and respect as everyone else.
And I completely agree. If you remember one of my slides that had that picture of what I see in the emergency department, fortunately, I don't remember the insurance status being front and center, but I'm also in the emergency department. So we are required by federal law to see everyone that comes into the ER. So I feel that we are in a unique position to just gloss right over that and treat every patient that comes in. But it does come up, and it comes up towards the end of the visit when I've got to figure out where to send the patient next and how to refer them. And you look up and you see Medicaid, and you just automatically say, oh no, this is going to be a fight. It's going to be a fight because who's going to see them? Because they know they're not going to get paid well. And how many hoops am I going to have to jump to make sure they get to see their cardiologist or their infectious disease doctor, like Dr. Wright mentioned. So, so it absolutely impacts. And a lot of things. It's the language that you speak, the color of your skin, your insurance status, whether you are an able-bodied person, whether you have any mental health disease. These are things that absolutely impact our care. We have to work out ways to acknowledge that bias and also ensure that patients still get quality of care. Another reason why I said that we have to look at our data, because if our Medicaid patients are getting worse quality of care, then we got to do something about it. And I think if you look at the data, that is absolutely the case.
Thank you both for answering that last question. So I just want to thank both of you for joining us today and trusting us with your stories and sharing your experiences, answering all of our questions and giving us action items. So that way, you know, we can all continue in this fight for health equity. Lastly, I just want to talk about a few things that we have coming up with Expecting Health. Our program, Baby's First Test, is currently accepting applications for its 3rd annual newborn screening, Generating Real Action by Cultivating Engagement, or in other words, GRACE Award. This award helps to highlight programs and initiatives that are dedicated to gracefully and authentically engaging families and communities in newborn screening. So you can scan this QR code if you want to read the full announcement and learn more. And lastly, our program, the National Genetics Education and Family Support Center, also known as the Family Center, has an upcoming webinar about implicit bias. So it's kind of continuing this conversation. This is just going to look at it from a different lens. And that will be Tuesday, August 15th. You can scan this QR code and learn more as well. And with that, again, I want to thank you both so much for taking the time to join us today and share your expertise and your commitment to health equity with us. And I just hope everyone has a great rest of your day. Thank you, everyone.
Thank you.
Thank you.